Hi, everybody. Welcome to today's Student-Led Journal Club. Today, I'll be introducing student Dr. Ramirez. Student Dr. Ramirez is currently a Kansas City Anatomy Fellow in between her second and third year of medical school. Originally from New Jersey, she graduated from William Paterson University with a degree in biology and worked as a scribe for CityMD after graduating. She's currently interested in pursuing general surgery or ObGyn, and she loves to read historical fiction, paint watercolors, and weightlifting. So with that, take it away, student Dr. Ramirez.
Awesome. Can you guys hear me? Awesome. Thank you for the introduction. So I'm just going to jump right in. So I'm Sirai Ramirez. The project I worked on this year is called a cadaveric study of the deep dorsal vein and the superficial dorsal vein for penile transplantation to transgender males. So I included my abstract that was submitted to the AACA conference, and my IBC number is placed there. So I want to start off with a little bit of background regarding the transgender population and gender dysphoria. So gender dysphoria, which was previously termed gender identity disorder, is defined as an incongruence between the gender identity and the sex assigned at birth. And it has been found to start as early as childhood. Research has shown that there is significant distress associated with the person's primary and secondary sex characteristics. It has also been noted that there is an increased prevalence of co-occurring mental health disorders in the transgender population. These mental health disorders for the transgender population range from increased poor self-esteem, increased rate of self-harming behaviors, suicide, depression, and increase in substance abuse disorder among this population. And so for those who desire, they can seek gender confirming care, which can include hormone therapy or gender confirming surgeries. And that is a procedure that will affect a closer alignment between one's body and gender. And so these surgeries can include transitioning from female to male or male to female. There are also minor procedures as well, such as like hair removal or speech therapy. In a recent study, gender confirming care has been associated with decreased gender dysphoria, highlighting the importance of research regarding healthcare for the transgender population. So gender confirming surgeries can involve male to female or transitioning from female to male. Specifically for my study, though, we're focusing on gender confirming care for a transition from female to male. And so this can include removal of female organs, such as hysterectomy, oophorectomy, and a vaginectomy, as well as genital reconstruction. Common procedures are mitotoplasty or a phalloplasty. And so in a phalloplasty, it's a construction or reconstruction of a penis from any of these parts of the body here that are listed, such as the forearm, the thigh, or the lat. And so the phalloplasty is one of the most common surgical choices for transgender people interested in gender confirming surgery. So it's important to note that it is accompanied by an increased need for revisional surgeries, and it includes complications exclusively for transgender male patients, including urethral fistulas or strictures. And strictures have been reported to occur about 22 to 60% of the time, and the fistula is about 22 to 75% of the time. And so all this can result in more serious consequences of chronic infection, sepsis, and renal failure, as well as general compromised quality of life. Okay, so what is an alternative to a commonly performed phalloplasty? So there is the proposed alternative procedure, which involves a penile transplantation. So this procedure is currently only available to patients with genitourinary injuries and diseases that resulted in either a partial or complete penile loss. For example, the most recent attempt at a transplantation was a veteran who was injured during a bombing in Afghanistan. It has only been performed 5 times, I guess, in the entire world, 2 of them being here in the US. And in the past 6 to 7 years, there has been an increase in research for penile transplantations. But regardless of the amount of research that there is, there's still no surgical guidelines or even donor inclusion criteria yet for the transplantations. So this author right here, which I don't want to mess up his name, so I bolded it here. He conducted a cadaveric study and that proposed that in a possible penile transplantation, the level of the harvest for the penis should be determined according to the patient and the defect, where, for example, a transgender patient would receive a total allograft versus a cisgender male would, with a proximal penile defect, would receive a partial shaft allograft. And this is very similar. So what they're proposing here is very similar to, I'm sure you've seen somewhere in your feeds, either Twitter or Facebook, sometimes they have these videos coming out from like facial transplants. So the idea is very similar. So the face is transplanted with vasculature and everything. So this is kind of what they're proposing, but for penile transplantations. Okay. So another publication by this author, Selvaggi, he proposed an en bloc dissection of the penis. And so en bloc in this case means it would include the penis, blood vessels, the nerves, and as well as the urethra. And he did this whole study on, he studied this on cadavers. And so the structures that were deemed important to be anastomosed to the recipient vessels were the internal pudendal arteries, the dorsal nerve of the penis, the venous structures, and the urethra. And so Selvaggi also proceeded to explore the lengths and diameters of the internal pudendal artery, which is listed here as important to be anastomosed. And he studied those for the viability of the penile transplant. And so here comes where I come in, and I decided to go ahead and look at the mean lengths for the superficial dorsal vein and the deep dorsal vein of the penis for venous anastomosis sufficient to reach the recipient vessels for penile transplantation. And so I chose those two veins, given that they were structures deemed important in literature. And so I decided to go specifically with the SDV and the DDV. So here, I thought this was interesting to include. So here you have two procedures that were attempted in 2017 and 2016. You have here one that was performed at Johns Hopkins. This is the most recent one, and you can, I don't know if it's like too tiny for you guys, but I'll try to do this laser pointer. And you can see here they use the donor superficial dorsal vein, and they also use the deep dorsal vein here. And then on this side, they use the deep dorsal vein and superficial dorsal vein. So again, they have been using these surgeries, so I decided to go ahead and do my study on those. And to clarify again, the penile transplantations have not been attempted on transgender males yet. Okay, and this is another picture I thought was really cool. This was from a publication that was actually published this year. So what they did was they took all the surgeries that had been performed, the penile transplants that had been performed to date. One was excluded because they didn't publish any work on it or any commentary on it. And so what I thought that was cool was that they put these side-by-side images detailing the different arteries, nerves, veins that they use to anastomose to the patient, to the recipient. And it's interesting to see that they use, some of them use only the one deep dorsal vein, and two of the surgeries, both from the US, use the superficial dorsal vein and the deep dorsal vein. And I just also thought it was interesting that this one, they ended up deciding on an abdominal flap as well, along with the penile transplant. Okay, so for my methods, the study included a total of 18 formalin-involved cadavers. They were both collected from the Casey campus and UNMC, or the University of Nebraska. And the initial dissections for the cadavers were performed by, one was performed by Dr. Olinger, as we observed, and then before we performed it ourselves. And then, so what we were looking for here, the first vein, this light blue right here. So here is drawn the femoral vein. You have the great saphenous labeled in this different color, and then the light blue, which is the superficial dorsal vein. So what we did was we dissected both sides just to make sure what side the SDV, we would find the SDV. So because when I was looking for developing my methods, when I was looking in the literature, there was not a lot of information regarding exactly what direction this STV would go. So whether it go to the right or to the left. So it's just to be safe, we dug out both sides just to make sure we could find it, whether it was on the left or the right. And for our measurements, we did not measure any of the vein that was part of the external penile shaft, because for this study, we're only interested in the pedicle for the explant of the penis. So that is this length right here. And so we thought that if we included this length, we excluded this length because there would be variability of penile size between cadavers, and we didn't want that to affect the measurements. So we measured the vein from about here to the pubic symphysis as a reference point, and then we did this point again to where it drains into the great saphenous. And those were measured with length calipers. All right. Okay, so for the second vein, it's the deep dorsal vein, and we hemisected male pelvises for this. We wanted to make sure we measure the deep dorsal vein down to where it meets the preprostatic plexus. And so what we were looking for, again, is like you don't want any of the vein that's on the external part of the penis. So we roughly measured from about here, which is about at the level of the pubic symphysis, down to the preprostatic plexus. And for the plexus, we were looking for like a bundle of veins that would be located in that region. And then again, these measurements were taken with length calipers, and everything was recorded on Excel. And then we used the IBM SPSS statistics to run independent t-tests, Spearman correlations, and descriptive statistics. So for the first test that we ran, we did an independent t-test for this measurement right here, which is shown here, of the SDV going to the great saphenous. So while we were data collecting, we noticed there were SDVs going to the right and to the left. So we ran an independent t-test to kind of compare those two means of those measurements. And there was a mean difference, but it was not statistically significant. So what we did with that is we compiled all those measurements in one column to run the descriptive statistics. So here are our descriptive statistics. We included BMI and age, which was also collected from each of the cadavers. We have the SDV to great saphenous length and the DDV to preprostatic plexus as well. The averages for the BMI was about 23.2. The age was upwards of 79, and it's a little on the older demographic. And then here are the average for the SDV to the great saphenous length was about 84. And then the DDV to preprostatic plexus is about 72.9. And I wanted to bold this here just to point out that two of our cadavers didn't have any information for the BMI. So that is gonna be a little less than this end right here. Okay, so then because we also collected BMI and age, we decided to do Spearman correlations, correlating it to the length of the DDV and SDV. But here we have the correlation between BMI and the length, which is shown here. This is the measurement, just as a refresher. And then here's the age compared to the length. So one of them, the BMI and the length, have a positive correlation, and the age and the length of the DDV had a negative correlation. But again, these were not statistically significant. Here's the correlations we ran for the SDV. So again, BMI and the length of the SDV to the great saphenous, we had a negative correlation. And for age and the length of the SDV, we also had a negative correlation, both of these being not statistically significant as well. Okay, so just to kind of summarize a little bit, these were the trends that we observed from our data. So for example, a cadaver with a BMI, a higher BMI, had a shorter SDV length. A cadaver with an older age had as well a shorter SDV length. And again, all these were observed, but they were not statistically significant. Okay, and lastly, we have our anatomical variations for the superficial dorsal vein. These were encountered while we were collecting data for this vein. So just to orient in the picture, here's the femoral vein. the great saphenous vein in light blue here, and then the superficial dorsal vein here, and it's pointed to by this little black caret. So when we were dissecting, we found that it drained to the right about 44% of the time, to the left about 38% of the time, and then bilaterally 16% of the time. And for the deep dorsal vein, which is located right here in the middle, that was consistently found midline. We did, at least from the 18 cadavers that we dissected, didn't find any variation with that vein. Okay, so in this study, we observed some trends between BMI, age, and the SDV and DDV lengths, but these were not statistically significant. We also came across some anatomical variations regarding the superficial dorsal vein. And this is one of the first studies to explore venous structures of the penis for specifically an unblocked dissection and transplantation. A common occurrence reported from the attempted transplants includes a lot of postoperative edema and necrosis, and several studies have actually advised anastomosing as many draining vessels as possible to minimize those bad outcomes. So that's why the DDV and the SDV are important, because they play a major role in penile venous drainage. And again, reviewing those 5 transplants that occurred, there was an increased venous anastomosis was positively correlated with graft drainage and health. So understanding those mean lengths of the veins and the variations of those would also allow for surgeons to use both the SDV and the DDV to make a more viable transplant. While the correlations, again, between the BMI and age and the lengths that were measured were not significant, this study can potentially provide a foundation to explore optimal age and BMI for a potential donor for this procedure. Again, for the 5 transplants, the phalluses were procured from brain dead donors, and it has been recommended in the studies or in the commentaries of these surgeries to ensure that the donor has a long pedicle. So that would mean like the nerves, the arteries, and the veins, and a variety of vasculature in order for that transplant to be viable. And another potential option that is being explored that was cited in one of the papers is that they're trying to consider including donors who desire male to female surgery, because they can donate their penis for someone who wants to transition from female to male. It is also important for a surgeon to be aware of the venous variation that we found in the study, for example, when harvesting the pedicle for transplantations. For example, if they know that either the SDV is right, left, or bilateral, if it is found bilateral, for example, the surgeon could anastomose both veins to improve viability. And then to sum it up, penile transplantations are a bit of ways from being an available option for the transgender male population. And plenty more research is needed regarding donor and recipient anatomy and vasculature to establish strong surgical guidelines, as well as donor inclusion criteria. So future directions, so some ways we could take this is replicating a similar study, but maybe in a younger demographic, since the mean age for this one was about 79. And then increasing the sample size of the study. We're also exploring any of the other arteries, nerves, veins that can potentially be used. For example, one of the plastic surgeons that I spoke to in regards to my methods, he said he was in the process of doing his study on the nerves that were important for penile transplantation. So any of the other anatomical structures could be explored as well. So limitations, again, as I said before, the cadavers there was a mean age of 79. So in regards to donor inclusion criteria, the older demographic may not necessarily be the optimal candidate for donors. So again, further research is needed to establish that. And then one thing that I didn't do in the study that the Selvaggi et al. Did was he explored the length of the internal pudendal artery, but I did not do the diameters because the cadavers were preserved, so they would not reflect those hemodynamic properties. And so those measurements would not be as valuable. Okay, so the total penile allograft for the transgender males would require harvesting a long vascular pedicle for an en bloc dissection as proposed. And it's therefore important to know the lengths of the neurovasculature proximal to the explant to allow for a better viability of it. And then understanding lengths and variations is beneficial for the surgeons performing the proposed penile transplantation. So as we work on the manuscript, hopefully in the upcoming months, these are potential journals for publication, including the Journal of Sexual Medicine, Plastic Reconstructive Surgery, Urology, and Clinical Anatomy. Just wanted to give a shout out to all these people here because they played some important role in either my IBC, my methods, my data collection, and all my questions. So thank you to you all and my fellows for helping me. And here are my references. Any questions or comments? Should I keep sharing this or should I minimize it?
Yeah, you can leave it up.
Okay.
But thank you. That was a great presentation. Thank you so much for doing this. Again, is there anyone have any questions or comments? Feel free to either raise your hand or type it in the chat.
I have a question.
Yes.
Now I came in late and I apologize for that. And I just, how many specimens did you use in your sample?
In my sample, 18.
Oh, okay. That's why you want it. Because sometimes if you have 30 or something like that, and you get something that's significant.
Yeah, I was thinking that that's probably why.
That's pretty cool in and of itself. And it doesn't necessarily mean you have to have a larger sample depending on what you're doing. Just this is really important research, and I'm glad you're doing it.
Thank you.
Okay.
Well, I definitely agree. This is very important. Dr. Wolf, do you have a question?
Sure. So I was curious why you use the body mass index, because I've seen a lot of, heavy people where it seemed like the penis was kind of pulled up in there. And so it seemed that, height or without getting too crass, hand size or things like that could potentially be relevant.
So your question is why I use the BMI or
Yes.
regarded the BMI. So the study the one by the previous author, Savaji, that I mentioned before, he also, when he collected lengths and diameters, he also stratified his data by BMI. I don't know if he found anything significant as well from that, but I decided to also include the BMI and age in that.
You presumably also have the height though, right? I mean, you could perhaps easily go back and look at that as well. Or, and then whether or not there's race effects, you didn't necessarily have a large sample size there, but.
Yeah, I don't think we had information regarding race for the cadavers, but I definitely could. That's definitely a good idea to look at the weight as well as the height separately. Thank you.
Thank you so much again, student Dr. Ramirez. That was a great presentation. Thank you for everyone who joined us today at the Journal Club. As I always say, this is weekly, so we hope to see all of you back next week for another really good presentation. Next week's presentation is a NERV presentation. So NERV is the club that we partner with, and they're a neuroscience focused group that is international. So I'm not sure where our speaker is from this time, but it looks like the topic is going to be gender equality in neurosurgery and strategic goals towards a more balanced workforce. So we hope to see you back next week. You can look for my announcements for that. Thanks again, everyone. Have a really good weekend. And thank you again, student Dr. Ramirez.
Thank you.
Yeah, good job, Sirai. You did a great job.
Thank you.